All right. Hello, fellow Wichitans. My name is John Rolfe, and I get the honor to MC today's Zoom call with just a really wonderful set of people who are serving our community in mighty ways the last year and a half. So around me on this screen, you see our area CMOs, which means Chief Medical Officers, who are really in the trenches, running area hospitals and have a great sense of what's going on. I'm co-chair of the Greater Wichita Partnership, and the Greater Wichita Partnership and the Chamber of Commerce have partnered together to give you access to this group of people to hear what's going on in our healthcare system. Both those organizations are focused on creating a robust economy in Wichita, and we all know to have a robust economy, you need reliable and excellent healthcare. It's been a strength for Wichita for a long time. We've enjoyed great partnerships with healthcare. Wesley and Via Christi and oftentimes the VA have been doing weekly calls with the city and county. And so you'll get a sense of what that looks like, where we'll start with a report out of what's going on at each of the area hospitals and at McConnell Air Force Base. We're grateful to have Dr. Alders with us also. And then we'll hear about the transfer situation across the state and in our region with Dr. Watson, who created some software that the state has been using to help transfer patients up and down the different levels of care. And then we'll have a summary of where COVID cases and all that are at in our community. And the hope is by 11:40 that we're in a question and answer period. The goal of this was not to create any policy or to recommend any of that, but to create kind of a single point of conversation for our community. We know we have a lot of business leaders on this call. They're trying to make decisions what to do in their business or their family or their church or other organizations they're part of as what's going on in the community. We also have several elected officials who have difficult decisions in front of them. And so we're trying to create a conversation to know where we're at, what's going on, and to make sure that we have a good sense of how we're doing collectively. My goal, so obviously I'm the only person on here without an MD after my name. I sling tacos and scrambled eggs and all that for a living in the restaurant space, but have had a chance to work closely with the healthcare system through the pandemic, and will try and serve not only as an MC, but a translator if the language gets clinical or difficult to understand, to make sure that it's translating out there into the general populace here. So we're grateful that you've chosen to participate. We have over 350 people attending today on this Zoom. We are also recording the Zoom so that it can be available for some people that have missed this. And I want to thank our partners who are on this, and we'll let them introduce themselves as we go around the round table, which is what we'll do now. They'll let us know a little about what their census is on patients, their ICUs, the availability in their ICUs, what they're seeing with vaccinated versus unvaccinated patients, trends here over the last couple of weeks, what's going on in their emergency departments, what they're seeing from a transfer situation, and also a staffing situation. What happens in hospitals, just as a level set, is you get bottlenecked in one of three places, or sometimes multiple. There's three S's. It's usually stuff, space, or staff. And when the pandemic started, stuff was the main bottleneck. You know, PPE, personal protective equipment, ventilators, things like that. Right now, it is a staffing issue. You can have a bed, but if there's not a nurse or a doctor there to help, it's just another bed in town. And so we're going to start with this report out with our regional partners, with Hutchinson and Newton, as they pull in from critical access hospitals, which are the smaller hospitals in the rural communities in there. And then as people move up in the need of trauma and more acute care, they're coming into these larger medical centers in Wichita. And so let me start with Dr. Degner and Hutch, if you can begin with your report out, sir. And you're muted, Rex. Thank you.
All right. Sorry about that. Greetings from Hutchinson. Yes, I'm Rex Degner, Chief Medical Officer up here at Hutchinson. And yeah, things are busy on a lot of levels. We have, currently we have 8 COVID patients in-house, which if you talked to us last November, that would have been nice. We were handling it the best we could back then. And we have a total of 75 patients in-house too. A couple of things that are going on is we see our general census climbing, partly, I believe, because patients put off some of their health care over the last year and a half, and they're now coming in, getting appropriate things taken care of, and we're just generally busy. On top of that, we're starting to see a resurgence of COVID cases coming in. Again, like I said, we have 8 in-house, 6 are in isolation, 2 are out of isolation, only 1's on the ventilator. Back when COVID first started, we were short of PPE, we were short of this, we were short of that. We now have, 500 days worth of masks on hand. We've got 200 days worth of gowns. We've got plenty of stuff. We have all that. We also have 40 ventilators that we could potentially bring into use here. We have plenty of bed space that we can use. What we have is a significant shortage of mostly nursing personnel, but some techs and others to help fill those beds. And so that's where we're running into the crunch. We're sitting here in the middle a little bit here in Hutchinson. We have critical access hospitals up in Lyons and Ellenwood and elsewhere that feed into us. And then we feed on into the larger hospitals in Wichita. And we're working diligently both with Wichita hospitals and with our feeder smaller hospitals to try and appropriately pace patients. Some of our lower acuity patients we're trying to send back to the Lyons and Ellenwoods of the world so that we can free up space for sicker patients. And then when they come, beyond what we can handle, we're having to pass them on. Of our 8 COVID patients we have in-house, 2 of them were previously vaccinated. And we've been following this. This is, for the most part, most of the patients that wind up in the hospital that have been vaccinated have significant comorbidities. They have significant other things going on with their health care that, besides COVID, even an influenza or a bad cold sometimes is enough to tip you over the edge. So we're seeing some of that in our vaccinated patients. Most of them, and some of them have underlying conditions where the vaccine probably didn't take. They have immune system problems where they probably didn't get a good response to the vaccine, hence they're coming down with it again. So I want to stress the vaccines are protective. They may not be all the way protective from you getting it again, but they are very protective about you getting it serious enough that you're going to wind up in the hospital. And I want to stress that point with this. And the ones we are seeing in the hospital, even the ones that have been vaccinated, usually have significant other problems going on that helps explain why they wound up back in the hospital. As far as some of our other numbers go, we have, of course, nursing shortages, employee shortages that at the beginning of the pandemic, when a lot of outpatient services kind of went on hiatus, we were able to borrow nurses and stuff from those settings and bring them in and use them. Now they're running full and busy, and a lot of healthcare providers have opted to leave the profession. It's very tough. It's hard work. Round 2's coming. It's very tough on them. It's tough to find nurses now. We currently have 5 employees out sick, 4 of which have COVID. We have a significant vaccination rate amongst our employees. It is 80+% of our employees have chosen to get the vaccination, which is good, but we still do have some out. I think the short story is we're running at capacity. We currently have 1 open ICU bed right now, and that happens to be, as of this morning, our only open bed. As far as able to take in a new patient, we're going to have to find a way to discharge one or do something like that. So we very much are at capacity right now and work it hour by hour about where to best shift patients.
Thank you, Dr. Degner. Appreciate it. Let me introduce Dr. Craig from Newton.
Thank you. Can you hear me?
Yes, we can.
Okay. I'm Charles Craig, CMO of Newton Medical Center. And first of all, thank you for allowing us to be part of this program. We currently have about 66 patients in the hospital. 9 of them have COVID. 3 are in ICU, and 1 is on a ventilator. Only 1 of these patients has been vaccinated, and that's probably been the trend, that very few of the patients admitted are vaccinated. And the age range that we've seen is from about 18 to around 55. As Dr. Degner suggested, it's quite different than it was in the winter. We were seeing 30 or more patients at a time. And then earlier this summer, it went down to 0, which was very nice. We've seen over the past 2 months, though, a marked increase, particularly in our outpatient clinics and the ER. It is generally doubled in occurrence. We have about 7 employees that are out with COVID. So far, our supplies are adequate, and we do have some capacity for taking patients. We've taken patients from around the state as well as from Springfield, Missouri in the last month or 2. We have had trouble with transfers to facilities that are on diversion. This is of concern to our EMS director here because it ties up our EMS transfers, have to go further places, often to Kansas City. And that's a concern for us. Generally, as Dr. Degner suggested, our patients seem sicker. I think they've put off getting health care, and the ones that are coming into the hospital are sicker. Our hospitalists and frontline staff are fatigued and frustrated. I think they would all encourage everybody to get vaccinated and wear masks when appropriate. I think that's our overall message to the people we see and talk to. That's all I have. Thank you again for allowing us to participate.
Thanks, Dr. Craig. And when you say you have capacity, is that in general beds or in ICU or both?
Well, we have a few general beds, and then we do have some in ICU left, yes.
Okay, thank you. Now let me turn to the VA here in Wichita, the Robert J. Dole VA Medical Center, and we have Dr. Ramesh with us. We're grateful to have you. Tell us what's going on over there, Dr. Ramesh.
Good morning, everybody. Thank you, Mr. Rolfe, for introducing me. I'm Dr. Ramesh, the Acting Chief of Staff at the Robert J. Dole VA Medical Center. As mentioned earlier, for the past few months, and particularly for the past 2 to 3 weeks, we are at capacity, both in the ICU and the med-surg. Current today's census, we are at 31 total inpatients, and among them 4 are COVID positive, 1 in the ICU, 3 in the med-surg. The number of total outpatient positives, majority of them are unvaccinated. One of the unique things that I have to mention as an internal medicine primary care physician is that we have a very good process of monoclonal antibody infusion here. And so far we have given since November to now about 70 infusion. And in those 70 infusions, there was only 1 hospitalization so far. So we are very happy to report that. And overall trend, as I mentioned before, majority of the patients are unvaccinated, and the ones that are vaccinated and hospitalized, as mentioned before too, that they have other comorbid conditions. And the ones that stand out is uncontrolled diabetes and obesity. And the age group is around 60 to 70s, majority of the patient that we have seen. Employee positives 2 out today, and for the employee vaccination, we have most of our staff vaccinated, about 80% so far. So we definitely highly recommend vaccination, and yes, it may not prevent you from getting the COVID, but it definitely decreases the severity. I have to emphasize that please continue masking and all other COVID appropriate behavior. Thank you.
Thank you, Dr. Ramesh. Now let's turn out to McConnell Air Force Base. We're really grateful to have Dr. Alders out here. Now they don't have a hospital on base, but they do have a lot of medical abilities out there, and she's over all of that. And she grew up actually in Goddard, and is grateful to be assigned back here. We're glad to have her back. She is limited on being able to talk about numbers, obviously, as national security, but she can give us an idea of what they're seeing at their clinics there on base. Dr. Alders?
Thank you, John. Good morning, everyone. Thanks for letting me be a part of this. As John said, I'm Dr. Alders out here at McConnell Air Force Base. Here at McConnell, we're an outpatient clinic. We care for our active duty service members in addition to their family members and retirees. In that population, we're definitely seeing a similar increase in our number of COVID cases, with a probably doubling in the new daily cases that we've seen this past month compared with months prior. We're also seeing an increase in the number of patients that are needing to be hospitalized, and we're very thankful for our local hospitals that are helping us to take care of those patients. We've seen the majority of our new COVID cases are in unvaccinated individuals, as everyone else is reporting and seeing. Those patients that are vaccinated that are having what we call breakthrough COVID cases, all of those have been genome sequenced and are shown to be the Delta variant. The majority of those that are vaccinated and come down with COVID seem to have a milder course, which we're thankful for. Some measures that we're taking here on base to try to help flatten the curve, reduce the spread that I'd like to share is our SecDef has mandated masks on all federal ground. So we all wear masks here when we're indoors, and we're thankful to have that policy to help try to flatten the curve and reduce spread. Additionally, we're taking some measures to try to encourage vaccination. It's not yet mandatory for active duty. It's looking that will be coming here in the very near future. But right now, we're trying to encourage vaccinations through incentives such as offering a day off after they've completed their vaccine series. And then we're also requiring higher level approval for leave for our unvaccinated individuals who want to leave the local area, because we know those individuals that are unvaccinated are at higher risk for developing COVID, bringing it back to the unit, sharing with others, and then having an impact on our mission. So we are requiring higher level approval and risk assessment for our unvaccinated members that are wanting to take personal leave. Additionally, we're continuing to conduct contact tracing and encouraging our members to stay at home and seek medical care if they're sick, as opposed to coming in and trying to continue on with the mission, trying to really prevent that spread. And I think that's all that I have here. Thanks for letting me be a part.
Thanks, Dr. Alders. And I assume SecDef, is that Secretary of Defense?
You got it.
All right. Yeah. So, I know there's the Q&A is starting to pop up, and we'll get to those, but I know there's a lot of businesses trying to figure out what policies and things they should put in. And as you're saying, Department of Defense has put in a mask policy indoors there. Is that for both vaccinated and unvaccinated?
Yes, it is.
Okay.
Yes, it is. Vaccinated or unvaccinated.
And then you said a higher threshold for leave if you're unvaccinated for the risk that you might get it and bring it back into the base.
Right. It requires higher level approval than just the immediate supervisor. Has to go up to the group commander to approve and do a risk assessment for personal leave.
Well, thank you for your service to our country, Dr. Alders. We're grateful to have you here.
Thank you.
Okay, now let me pass it to Dr. Ebersole with Wesley.
Good morning, everyone, and thank you for the invitation to participate in the call today. Wesley's total census today is 415 patients on our inpatient side. Of these, our COVID census is at 69, so that's 17% of our inpatient admissions are COVID positive patients. 36 of these COVID patients are in the ICU, and we've been seeing this trend at our facility where about 50% of our COVID patients are requiring ICU level of care. So we're closely monitoring that because it's a little bit higher than we saw with the first wave. We have 10 COVID patients that are currently on ventilators, and our ICUs are at 100% capacity, our adult ICUs. We've seen similar trends in terms of vaccination status. 97% of our COVID patients are unvaccinated. For the minority that have been vaccinated, these are breakthrough infections in patients that have comorbidities or immunosuppression. Our COVID hospitalizations, our data really shows that this has shifted to a younger age group, particularly the 34 to 55 age group now comprises 31% of the hospitalizations since May. as well as 30% of the mortality. So this age group, 3 of every 10 patients, unfortunately, are succumbing to COVID. In short, these patients are unvaccinated, younger, sicker, and staying longer at our facility. Our ER volume has definitely returned to very close, if not surpassing, our pre-pandemic numbers. This is COVID and non-COVID. A difference being with the first wave is people were staying home. Unfortunately, they were also putting off coming in for acute issues and certainly putting off chronic illnesses that they needed to potentially, say, a knee replacement surgery and such. Right now, I have 17 holds in my main ER here at Wesley Hillside, and 9 of those are waiting on ICU beds. And this is a daily trend, unfortunately, due to the volume that we have and just overall both COVID and non-COVID patients.
And Dr. Ebersole, let me interrupt just real quick. When you say holds, that means that they need an ICU bed, but there's not one available. So they're sitting in the ER, taking up an ER bed because there's people in the ICU. Am I understanding that correctly?
That is correct. So right now, we have 9 ICU and 8 med-surg waiting for, and these are a combination of both potentially COVID and non-COVID patients. Our ED providers, then they turn over the care to our hospitalist team, and they come down to the ED. But you can imagine trying to provide inpatient care in an ED setting hours and hours on end is not ideal, and we don't want that for our patients, but we're doing the best that we can to provide that care.
And one follow-up question, when you get into a situation like that, I think it was Dr. Craig mentioned hospitals be on deferral. That means they're saying, don't bring transfer patients here. Our ER is full, we need to find another hospital. And that is what would contribute to that, right? Is the backlog then coming into the emergency department?
Yeah, so there's 2 levels. One's called transfer closure, where Wesley would no longer be accepting patients transferred outside of Sedgwick County. And we've actually been on that the vast majority of the last 3 to 4 weeks. We've been on transfer closure since last Saturday, so going on 6 days now. The second level is called diversion, where we actually they divert ambulance traffic in Sedgwick County away from Wesley. But I believe Via Christi is also on diversion at this time, so that means nobody's on diversion essentially. So we're talking to Dr. Antonios, Dr. Beard over there. We're very much in similar situations, and we talk pretty frequently. So that taxes the system overall for sure.
And I assume that's rare, pre-pandemic, that both of you would be on diversion.
It was fairly uncommon, yes.
Sorry, you can keep going with your report out.
Okay. All right, thank you. So just to give you a sense of what that means, the last 24 hours, we had to decline 28 patients that requests came in to our transfer center, places where Dr. Degner, Dr. Craig are trying to transfer these patients in, and others for a higher level of care, and we had to decline them. The biggest reason why is it's a staffing shortage, predominantly nursing, but it's also areas in respiratory therapy, OR scrub techs. I mean, you go down the line and we have some significant shortages, but the most predominant is our national nursing shortage that we have. Wesley blocked 41 beds overnight due to our nurse staffing shortage. And those are beds, we have physical beds and capacity, but as I think Dr. Degner said earlier, we don't have the nurses to staff those right now. We do have 6 staff that are currently out with COVID. And I just want to put a plug in for them. They're very, just our nursing staff, our respiratory therapists, physical therapists, case managers, everyone is just very physically and mentally fatigued. This is the second go round for some facilities. It's the third go round with COVID. And we can certainly impact this by wearing masks consistently, vaccinating yourself, and encouraging others to do so. It's a personal decision. Certainly, all of us on the call, I'm sure, are happy to provide education, answer questions for those that are maybe questioning that, and provide those answers for them. But we're here to serve the community in our state, and we want to continue to do that to the best of our abilities. I'll turn it back to you.
Thank you very much. Now let me pass it over to Dr. Antonios via Christie.
Thank you, John, and thank you everybody who has joined the webinar today. Today I'll give a report of what we have currently in the hospital. So as of last evening, we had 70 patients who had COVID-19 in the hospital, with 18 of those who are unfortunately in the ICU. Now that number may not mean a lot, but I'm going to give you some context. Early July, so just before the July 4th holiday, we were about only 10 in the hospital. So we're about 7-fold that now. And there was only 2 or 3 in the ICU. So really at the beginning of July, we have seen this steady increase in the number of COVID-19 cases in the community and coming into the hospitalization. Like everyone else, we have about, our percentage is about 94 or 95% are unvaccinated who are being hospitalized. The rare few who are vaccinated generally have another maybe immune condition that has blunted their immune response to the vaccine. And in fact, that's part of the reason why now the FDA, if you might have heard yesterday, has cleared a third booster it's really for these kind of patients who have gotten the vaccine, but there's something in their immune system that didn't really pick it up. But for the vast majority of people who have received the vaccine, it has been incredibly effective. The vaccine really works. It has been preventing hospitalizations, and the data does show it. We've noticed that we've unfortunately seen more deaths since this recent rise, and that is concerning to our staff. Our staff I'm very proud of them. They're very committed and dedicated individuals, and they have seen a lot of death the last fall and winter. And as they have started to see a new increase in the deaths, they're somewhat disheartened, and they really want to urge the community to take steps so that this doesn't continue and we can prevent it, because these are deaths that are, for the most part now, preventable. Another thing that I'll comment on is that our physicians, our hospitalists, our infectious disease docs, intensivists, they're noticing something different with this Delta. They're telling me that it just seems to be making people sicker faster, and it's different than last year, and that is explained most likely by it's a different variant. And the other thing that we're also noticing, and I'll give you a little bit of stat about this, over the last just 45 days, we've had almost, not quite, but almost the same number of pediatric cases than we've seen in a previous 15 months. And so that it seems that we have more kids impacted today. We know from other children's hospitals that we're familiar with, they're noticing the same trend. And that's just because of the Delta variant seems to spread a lot faster in their communities, and it can impact kids, and it's reaching kids faster. And that's obviously important. Since the Delta spreads faster, it is also impacting our staffing. That we have several associates or employees who are out on furlough because they have caught COVID-19. But what's interesting is, and we see this in our own data, when people who are vaccinated from our staff who have gone, obviously they have to quarantine because of that they caught the disease, they're generally not all that sick. It's a mild disease if you've been vaccinated, but it's a more severe disease if you've not been vaccinated. And we see that in our experience. That's really kind of a summary of what we're noticing. Patients getting sicker quicker, younger, more pediatric population, certainly amongst the unvaccinated. We know masks work. We obviously recommend masks to all people, vaccinated and unvaccinated. That is something that the CDC today recommends. And the reason for that is that we really need to be able to bend the curve and control the spread in our communities. That will help in the short term. On a little bit of a longer term, because it needs a little bit of time to kick in, getting more people vaccinated. It takes about 2 to 3 weeks for people who get vaccinated to really become immune. And so short-term masks will work, longer-term vaccines will work.
Thanks, Dr. Antonio. Two follow-up questions. So from a capacity question, your emergency department, are you seeing similar to Dr. Ebersol as far as any kind of backlog in your emergency department, waiting for beds?
We've seen an increase in the number of visits already, an increase in the number of requests for beds from surrounding hospitals. You know, a hospital is a very fluid place where, and I think you're familiar with that, I think from just your line of business as there is, it's always happening, it's not static, but we have seen the times when it is very busy or extremely busy be much higher in frequency than before. We do our best to be available for the community and make sure that we're able to accept patients. There has been time where, because of the volume of patients coming in, there could be delays in how quickly can someone be admitted to the hospital.
Dr. Antonio is referencing when we were discussing earlier, when I first started leaning into this, I tried to figure out what were the two metrics that were going to tell us when we were tipping over to our hospital system becoming overwhelmed. And what I learned was that it's a lot like a restaurant kitchen, which is the business I'm in. I can be in a restaurant and tell when the kitchen's close to going down, but it's about 1 of 16 things that can take the kitchen down. It could be someone spilling a pan of salsa. It could be someone, getting a call from a spouse that they need to run home, or it could be a busload of people pulling up outside. There's a lot of things, and hospitals are so dynamic. It could be someone that you think is going to be leaving, ends up needing to stay. But the trend lines, what I'm hearing you say, Dr. Antonios, are not good. I'd love to just follow up too on the pediatric numbers. If you can give more context to that too. I know Dr. Ebersol, you guys have a big pediatric focus there too. Do you have any thoughts on that that's going to catch people's attention, knowing that the pediatric cases are going up also?
So like I commented earlier, we have seen a little bit more cases in pediatric population. We have also heard that from other hospitals that I'm familiar with and I'm constant connections with. This year, there has been also RSV that has impacted kids, and it's really unfortunate when a child is exposed to both RSV and COVID-19 at the same time. That's usually not a great combination, and unfortunately, we have seen some of those. So the data is really showing that there just seems to be more impact on the pediatric population right now.
So am I translating that to say the severity may be higher when the pediatric population is getting it? Or is it just more?
Particularly if there's yes, and particularly if there's another viral illness that exists along with it. The concern for this fall because the fall is usually when kids tend to have the viral illnesses. And so if we already have this much spread early in end of summer and as we approach the fall, obviously accumulation of multiple viral illnesses for the pediatric population is a concern.
Thank you. Dr. Ebersol.
A similar comment, certainly we're seeing children, seeing a slight uptick in the COVID patients that are being admitted, but mostly we're actually admitting a lot of pediatric patients with RSV, which is out of season. We were all in masks last winter, and so that, and a lot of kids were not in school, so that decreased the number of hospitalizations. Concerning and talking to our pediatric hospitalist and PICU medical director going into the fall and winter, as Dr. Antonios was alluding to, concerning about, and then also combined with schools going back into session, concerning about kind of the double whammy or multiple infections at one time.
Thank you very much. Okay, now let's look at some slides here. I'm going to pass it over to Dr. Watson, who's a Kansas native and started this software that most of the hospitals in the state are using to transfer patients. And what that means, you've heard us talk about critical access hospitals, the rural hospitals. They don't have as much trained staff around high acuity, the same tools, the same specialization. And so they maybe have 10 or 12 beds designed to keep someone for no more than 24 or 48 hours. And they move into regional hospitals and transfer. And ideally, you want to be close to where you're from. And what we're finding, part of what Dr. Watson measures is how long it takes to find a bed. So you can imagine coming in with a heart attack, knowing that you need more acute care. They get on this software to look to see the closest hospital to move you to so that you can start getting well. And they're finding the time frame and the distance you have to travel, which adds to the time frame before you get the care you need, has gone up. And Dr. Watson has a view for the state of Kansas and locally. Dr. Watson?
Yeah, John, thanks for the invite and thanks for everyone on the call. It is unique. We're with Motion to provides mission control software to the state through a grant from the KDHE, and we're approximately deployed in 75, 80 hospitals within the state right now. We have a broad look at how the state capacity is from a bed standpoint. We also are able to monitor how patients move in the state and now between states during the pandemic. So the first graph I want to show you is a graph that relates to the percentage of patients who actually need or are requesting a bed. We know certainly in the fall of 2020 that we had a surge there, and we saw 45 to 50% of the requests were requiring bed finding assistance as well. And then the lull through the summer, everybody understood what the disease was doing. But I think very much the surprise was the speed of the uptick, the slope of this curve, how rapidly from the end of July to now things have changed. And now we're 75% of the callers are requesting a bed, indicating that there's significant problems finding locations for people who need to move. And I think I want to stress that while we talk a lot about COVID patients, that people who are vaccinated and have non-COVID diseases are caught up in this same story, that you may have a heart attack, you may have a stroke, you may have a loved one who needs critical services, but you're in the same pool, the same process that it takes to move a patient from one hospital to another. And so those difficulties are not just with COVID patients, but significantly affecting the ability to transfer people who have very time critical illnesses within the system. The next graph shows a little bit, in a little bit more succinct fashion, the curve that we saw. The gray bars are representation of transports in the process. The actual lines, the individual colored lines, represent the percentage of the beds that are full in the state. So if you see on the right-hand side graph, if it's a 3, if we're up to 3, that means there's absolutely no capacity in the state to move patients around. And you can see that COVID ICU beds, that particular dark red line is higher than it was in the fall surge at any one time. We are now more critical than we were even at the height of the surge, not because just the numbers of COVID patients, but because the number of actual staffed COVID beds has decreased. And so while everybody may look around and feel that the impact of the disease may not be what it was in the fall, and there's this sense of well-being because the vaccine's out there and everything was getting back to normal, in reality, we're surpassing the problems that we had in that first cycle, and they're much more important now than they were before. We do bed status checks. We actually call facilities. We keep track of bed availability on a regular basis in a broad brushstroke to help understand how people can move. And so Bed Finder itself, I think we'll pull that dashboard up. Red means no capacity. And as you can see, multiple days we've been at a completely red scenario where there is no capacity in the state. I know someone's asked, how long does it take? Usually with time critical diagnosis, like a heart attack, we expect there to be acceptance within an hour and moving that patient relatively rapidly. We're almost 4, even 4+ hours to even get to that place. We know that we're taking days in some cases to find beds for people, literally hundreds, and I do mean this, small hospitals, we are making hundreds of calls on their behalf to facilities in 5 and 6 states. We've transported people in the last 48 hours to anywhere from Colorado to Missouri to Wisconsin. We've brought patients from New Mexico. We're moving people all over the US, trying desperately to find beds for people. And while it may not seem to impact your daily life, what it does impact is it's impacting a lot of people's lives all over the nation. And I think that's the word here, is that the system is at a place that it's never seen before. Not what it was last fall, it's worse than it was last fall. And I hope general public can understand how significant this moment is. And even if everything goes back to normal today, the length of hospitalization is going to continue to hamper our situation. So lag in vaccine times, lag in the ability of people to get well. We're going to be at this level for 3, 4, 5 more weeks at the best case scenario. There's no question we'll continue.
Dr. Watson, thank you for that. That's very helpful. I was on another call with you, and maybe you can talk. So you also have visibility out of the state of Kansas. I heard you draw a triangle or a diamond around Kansas, saying at one point from Amarillo to St. Louis to Sioux Falls, South Dakota to Denver, you were unable to find a bed that you could transfer to once the hospitals were full in the state. Is that right?
Yes, that's correct. And I think you can't just say these are COVID patients that can't find beds. These are normal cardiac, normal stroke patients that we're not able to find beds. There just isn't capacity. You can create the physical bed in a room. You just don't have people that can do the job to take care of them.
Yeah, thank you very much. Now, one last presentation before we move to Q&A. Dr. Antonios, I just want to thank personally. He helped organize this group of chief medical officers, organize these slides. He spent a lot of time and effort into this on top of the busy demands of his schedule now. So thank you, Dr. Antonios. And just this is a brief update for our community on COVID cases.
Yeah. Yes, thank you, John. And actually, looking at the clock, I'll be brief and quick through these slides. A lot of this information is stuff that we have already covered. And so this, for example, shows how we are in comparison to the rest of the United States. Kansas, how is it in comparison to the rest of the United States? And adjusted by population, you can see that we're somewhat a little bit faster now moving than the rest of the United States in our progression of COVID-19 cases. This represents the number of new cases in Kansas. A lot of these slides, and by the way, I have a source on every page of these for where I'm getting the information from, mostly from KDHE and other public sources. Number of cases has been increasing in the state, as we have been discussing. So has been the number of hospitalizations in the state. And then when we try to look into why, this slide explains the why. What you're looking at here is the progression of the type of virus. So CDC and the KDHE conduct genotypic studies on samples of viral swabs to identify the types of virus. And we no longer have, almost completely gone out of the Alpha variant that was the original variant that hit the United States last year. And in the dark blue, you'll see the fast progression of Delta. Delta has taken over, and it's fair to say that if someone is infected with COVID-19 today, they have an 80 to 90% chance that they have gotten Delta as a cause of their disease. Why is that? As I mentioned earlier, Delta is just more contagious. You might have seen in the news, and this is a slide actually from the CDC, you might have seen them talk about how it is as contagious as chickenpox. So if you take the Alpha strain, it used to be, the Alpha strain was infecting on average 2 to 3 persons. So if someone got it, they could infect 2 or 3 other people in their surrounding. The Delta variant is can on average infect 6 to 8 people in their surroundings. So obviously as a result, it will spread much faster. This slide is from the Sedgwick County dashboard, and it shows the rise in the positivity rate that we have seen in Sedgwick County. Obviously here we're talking about the greater Wichita area, so not just Sedgwick County, but that's the county that has the easiest dashboard to be able to download from online. Like you mentioned earlier, we, the local hospitals, every week meet with the county to give them our numbers, and that's what populates this particular dashboard. And as you can see, in July, we have said it had a increase in the number of hospitalizations and ICU needs. If I put together Sedgwick, Harvey, Butler, and Sumner County, just to kind of get an idea a little bit of this region, and I know we don't have Reno on this one, but same trend that we noticed, an increase, mostly driven by Delta, both in number of hospitalization, and this one represents just the 7-day average of hospital increases. So when it comes to the vaccine, the data is really now very strong in favor of vaccinations. This slide comes to us from the CDC itself. They've done the analysis. If someone is vaccinated, just to catch the disease, they are 8 times less likely than someone who is unvaccinated to be hospitalized. It still can happen, and I want to make sure people know that if you get a vaccine and you end up in the hospital, it's not really proof that the vaccine doesn't work. It's just the frequency is so much less. So if someone is vaccinated, they are 25 times less likely to be hospitalized, and they are 25 times less likely to die. It's very strong evidence in favor of vaccines. Very safe, very effective, and the benefits certainly outweigh all the risks. And then finally, I was able to get this from the Mass General Hospital's model that they try to estimate the future a little bit to the extent possible of what might happen with COVID-19 in our state. And so this is for the state of Kansas in the kind of gray area there. Obviously, there's a margin of uncertainty, but if things don't change, if there aren't a more adoption of the masks or more vaccinations, there's an estimate here of what we could see in the number of cases in our community. And that was my last slide, John. Again, sorry for going relatively fast through it, but I wanted to make sure that you get the opportunity to address some of the questions.
Yeah, thank you, Dr. Antonios, and leave that one up real quick, just because I want to make sure I'm hearing you guys right. With the spot that we're at, are you able to put that last one up? Yeah, thank you.
There you go.
You're saying currently our hospitals are at capacity. I've learned when the folks running hospitals tell me that it's very busy, that's different than what very busy looks like for me. So you're saying that there's a chance with that rise. I mean, what's that mean for a Via Christi or a Wesley? Should that be right?
Well, the prediction is obviously concerning. We're working, day and night very hard to make sure that we're available to our community. But that's part of the reason we wanted to be on this call right today, is to be able to kind of transparently say that we are concerned about the trend that we're seeing. These are only projections, and so obviously there's always a caveat of uncertainty surrounding that. I personally think it's not too late. I think we even though we're kind of headed in a concerning pattern, if people can adopt quickly a vaccine and adopt also masks, we can prevent a lot of further challenges with trying to get patients in and hospitalized. So really the message out of this is to early adoption of masks and adoption of vaccine will be very, very helpful and needed.
Okay. Thank you, Dr. Antonios. I'll turn it right back to the panel before we take questions. Did any of you have anything after seeing all that data that you wanted to add that you thought we were missing or that you wanted to amplify before we move to questions? Okay, you all did a very, very nice job. Thank you very much for the report outs. Going into questions, the first couple were about, business owners trying to figure out how to set policy in their offices when they have a mix of vaccinated or unvaccinated. When you're thinking about that, how at risk are vaccinated from being around unmasked, unvaccinated, do you recommend that vaccinated need to be wearing masks in those situations? Anybody want to try and take that one on? Do I need Dr. Ebersol?
I'll share what we're doing here at Wesley, and I certainly understand that this doesn't necessarily translate 100% into the business community, as my wife points out to me. The hospital's a different environment. But we, due to the recent recommendations of the CDC and some of the studies that we've seen the results of, we've gone to a universal masking policy, irregardless of vaccine status within the walls of Wesley. Clearly, we have, in our COVID units and other units, we have very sick people, but this also includes our non-clinical staff. So we had some period of time where if you were vaccinated and less than 10 people in a room, say a conference room, you could be unmasked at that time. But due to the recent information and science data that we've seen, we've felt like it's most appropriate to go to 100% masking, unless you're in an office like I am right now by myself, because we do know that there can be transmissibility of even vaccinated individuals of the virus to others. So that trying to adopt that, I think in businesses to some degree, I would encourage business owners to do that and see what, how to keep their staff, keep their patrons, clients safe at the same time.
Yeah, Dr. Craig.
Yeah, our hospital too has adopted a universal masking policy and has ever since COVID started, whether or not you are vaccinated. Yeah. So I agree with Dr. Ebersol.
Thank you very much. And I'd add, I think it's been a game changer. I've even heard talking to you guys by understanding how different the Delta variant is and contagiousness. I know in our restaurant environments, just being a business owner, we never had an outbreak of more than 3 through the majority of the pandemic. In July, we had outbreaks of 11 and 13, which absolutely brought those 2 restaurants to a screeching halt. And obviously, you get concerned about your people. And so that had us relook at our policies and redraw lines. And I know people in banking and other offices, it's just not what we saw before when someone brought COVID into the office space or into your place of work. It is just that much more contagious that it's a fork. So we can think, if you don't want to just make it about health, the continuity of operation is a real good approach that we found in our business to think through the policies around that. Let me ask this question from Andrew Braun. Given what you've seen, how long will it be before we start knowing if a lack of masks in schools is a problem? Are we 2 weeks out from a potential spike in cases? 3? What do you all expect to see with that?
So, obviously we're not policymakers and we're not here to talk about policy. However, given what the CDC has recommended in regards to indoor masking, we think I speak for myself, I think it's very important that people follow the CDC guidance in regards to indoor masking. Could it be impactful? The risk is definitely there for a worsening if there is more spread within schools and other congregate settings.
Anybody have anything they want to add to that? The other thing I'd say is I do know, there's a guy named Scott Gottlieb that probably a lot of people follow, but he made the point that there's not many businesses in this country or probably in this town that would put 20 unvaccinated people in a meeting room for the whole day and think that was a good policy for their business. And that's just because of how rapid this thing can spread. And so, that might be in consideration there. All right, let me turn it back to the questions here. I'm very concerned about the staff shortage. What's the main reason for this major shortage? I know we heard a little bit. Does anybody want to add on to that?
I can make a few comments. We actually, even irregardless of the COVID pandemic, we had predicted a national nursing shortage. So unfortunately, this did not come as a surprise, but it happened to land in the middle of a global pandemic. So there had been a prediction around a shortage of around 50,000 nurses in the United States. What has been exacerbated this over the last 6 weeks or so is that nurses are being pulled to the hot spots in the United States, Florida and Texas. And many nurses are leaving they're traveling, and the pay is significantly higher for these traveling nurses, usually on the order of 3 magnitudes higher to go do this. And so it's created challenges certainly for our organization. I know I think all the organizations on the call, because we're all fighting for the same resource for nursing. And we've also seen this in other areas with respiratory therapy, surgical scrub techs, because we all need the same resource to staff our hospitals and serve our patients.
Thank you, Dr. Ebersol. And I'd add too, just as a frame of reference, because I've had this question come across about, well, why not just have the nurses cover more beds if you have a bed? Would one of you like to speak the level of care if a nurse goes from covering 6 beds to 12 beds, what might happen? Again, a restaurant analogy might be, you can go into a restaurant that normally would have 12 servers on the floor, and you can expect the level of service to be good. If there's 4 servers on the floor for that same set of tables, you can imagine what happened to your dining experience. But the consequences seem to be much higher in a hospital environment. Is that right?
So John, like you said, the analogy or the example you use is actually a very good one. We are very passionate about the safety and the quality of the care that we provide. And even though you can potentially sometimes ask people to do more and stretch them, it's really not without limits. And so the analogy uses it great, because we want to make sure we're still delivering the same level of safe and excellent care that we do.
And I think
yes,
I might add that the acuity of patients tends to be going up too. And so they tend to be a little bit sicker. The COVID patients require additional care. And so it makes it harder to stretch nursing personnel amongst other patients, just because the level of care in general seems to be going up a little bit too.
Yeah, and I think, as we have a lot of community leaders here and people trying to figure out what they can do, you guys talk about the mental health of our teams out there serving folks and how hard it is to go back into another season like this. And there's been a lot of national stories on it. So I've heard, from some of you that they were used to seeing maybe 2 deaths a week before the pandemic, and in surges like this, they can see as many as 20 or 30, and just how that wears on a human who are there to try and keep other humans alive and well. And so it's good for us as a community to be thinking about how can we encourage staff right now out there and celebrate them as they're really going through a very hard time. From a mental health suspect. Now, let me ask this next question. What are medical experts saying about the need for booster shots for the patient with normal immune systems? In other words, when do they expect to see effects of the vaccine wear off?
John, that's being studied, and the CDC is looking at the data. As I mentioned, just this week, there was the approval of a 3rd dose for patients who have immune problems. And as of now, and things could change in the future, no one really knows, but as of now, there is no recommendation for a booster dose. And this is how science works. You accumulate the data and you look at it and you find new evidence and you implement it. And so as the data gets collected, may or may not be a need for a booster. The good news that I want to tell people is that the current vaccine works incredibly well. It is very effective, and actually even more than we're used to, even more than prior flu vaccine doses that we used to get. So, and that's great. So we need to continue to encourage people to take advantage of really is a scientific breakthrough. So I'm confident that people have gotten the vaccine and they don't have any major immune issues that they're aware of. They're going to be okay.
Now we've hit the hour time limit. We have about 3 or 4 more questions. Are all of you able to stay on to just take on a couple more questions? Is that right? I know you guys have many needs to manage on your time. Okay, so what are the logistics for an individual patient experiencing a stroke when local hospital beds are full and the closest open facility is not an option due to distance or no open beds there? What happens then, assuming you would not send them home?
We've got a couple of things that are in place. Number one, what are traditional receiving hospitals? We obviously are looking to them first. We do know there's a subset of patients that could be moved to maybe a non-traditional referral center, but that someone that has the adequate services to be able to take care of that patient in a particular way. Certainly out of the area has come into play, although each state is dealing with this crisis a little bit differently, and they have their own set of problems with transports from out of state. And certainly in Kansas, we truly believe taking care of our own first, but still trying to be good citizens of medical community regionally. I'll say that we're looking more and more into, if we get into scenarios and we have that patients have had to wait days for placement in some way, to then be able to provide telehealth services to help manage patients locally while they are waiting for placements in some other facility. This is a stopgap measure. We realize it's not an optimal way to take care of people, but in these days, in these scenarios, when there physically are no places to move patients, this is at least coming alongside of rural providers to really help at least provide some management expertise on top of the current services that their hospital is able to provide. But very, very difficult situation if you're the person on the end of that care, trying to understand why in the United States we are having problems with getting the care people needs in different places. It's certainly unprecedented, well overused word, but just amazing moment.
Dr. Ebersol, do you have something you wanted to add to that? I saw, looks like you're still muted. Okay, all right. A lot of people thanking you guys for everything you've done. Will the staff shortage be improved when the expiration of expanded unemployment benefits? It sounded like you guys are not seeing that as one of the contributing factors to the shortage in the nursing. That might be other industries, but not necessarily yours. Is that correct? Okay. And then are you guys finding difficulties having visitors wear masks as they come visit the hospital? And do you have any words of advice to businesses who might want to require masks?
I'll just make a comment to that. We, for the most part, people understand that as a healthcare facility, we obviously, and as also as part of the CDC guidelines, we require masks. There are the occasional people who we have a challenge with convincing that they need to wear a mask, but those are kind of the rules. So we deal with it on a case-by-case basis. And I want to also add something here, that it is not only just our own decision because it's the right thing. We also follow regulations, federal and state regulations that require masking. So it is what needs to happen in every healthcare facility as part of local, state, and federal requirements.
Anybody else like to add? Okay, and then I had one other question just about pediatrics as far as, and I'll add just a little color around it. I know that the pediatric beds, the last surge, ended up being overflow beds for COVID patients. And what I'm hearing now is that your pediatric units are full or have enough capacity that those aren't available. And any other color or trend lines that you can talk about what you're seeing with pediatric.
At Wesley, our pediatric units are either at or very close to capacity due to the respiratory illnesses that we're seeing, RSV that's off season and others. And then also, it's summertime, so we have some pediatric trauma at our children's hospital that have required hospitalization here as well. So it's concerning given that capacity. We don't have, as you described, kind of that valve to open up as we did in the first wave. So we'll be watching that very closely.
And Kansas City did a similar call like this last week. I know Children's Mercy up there is seeing a significant spike in cases, and on that day it had gone from 12 to 19 COVID patients, and they were starting to hit capacity between the RSV surge, which you guys mentioned earlier. And so again, limited options for pediatric patients. There was a story I know in Texas about a baby having to be flown over 100 miles to find a bed that could care. And we know we don't want to get to that point. So I really want to thank you all for your time today. Any of you want to say anything in summary before I wrap it up?
Yeah, John, if you don't mind, I'll just say, well, first of all, thank you for arranging this, and thank you for everybody who has attended. And I want to thank also the panel who have shared their experience with us. So greatly appreciated. It's just in summary about really the immune system. And the way it works is when people have exposure to a virus, they develop an immunity to it. And that's why we generally, once you've had chickenpox, maybe as a child, you actually don't have it later. Some viral illnesses, you need another booster in order for your immune system to be able to respond to it. So that's kind of how immunity works. And wouldn't it be great if somehow we can create the immunity without actually exposing someone to the actual virus? I.e., how can we fake the virus to the body to create an immunity? And that's really what vaccines have been doing for the last 100+ years. They are very safely, artificially making the body believe that someone is being exposed to a virus without actually jeopardizing someone's health by exposing them to the real virus. And that's how J&J works. That's how Moderna works. That's how Pfizer works. So it's a real breakthrough in our understanding of how the immune system works, and we're able to safely improve our health. And I highly encourage people to take advantage of that. The other thing is, as we're facing these surges, we know masking works. Last year, I remember in the fall, we reached a point where there was pretty good adoption of masking in the community. In fact, it was so good to the point where we almost saw no influenza in our hospitals. Why? Because people were not giving it to each other because of the mask before the vaccine. So masks work, vaccines work. So definitely those are things that we encourage people to adopt. I think you're on mute, John.
The other message would be that you guys are near critical capacity. Find yourselves full on a way more regular basis, and that it's as bad as it has been at any point during the whole pandemic, or worse by Dr. Watts' charts. Would that be accurate as well as a takeaway from this? Okay. We want to thank you all. And Dr. Aldis, really appreciate what you had to say as people think about strategies. The Department of Defense laying out masking indoors as a way to keep our troops ready, mission ready, as you said. That was really helpful. And I just want to thank you all. I know as I reflect a lot of the community's voice in this, you all do so much for our community that we take for granted. I had a kid wake up with 104.5 red skin last Saturday night. And I was recognized, we're trying to figure out whether to take him to the emergency room or not, how much I take it for granted that you all are there doing your job with excellence, that I can have that option to go to. And we just want to be good partners back. We appreciate that you all are there and would commit this time today as we move around as a region. So thank you, and please give our regards to your teams and our appreciation. Thank you to the Chamber and the Greater Wichita Partnership for co-hosting this event. We will try and keep a beat on this level of communication for you moving forward. You'll have a wonderful day, and thanks for joining this Zoom call.
Thank you.
Thank you.
Thanks.